Good. So thank you, Peter, for your kind invitation. Thank you, Philippe Landreau, and all the Aspetar staff for this opportunity to talk about anterior ankle impingement, especially in soccer player. So basically, I think everybody knows all about anterior ankle impingement. My topic will to know if there are something new in these problems. So this is my disclosure. So basically, the pathophysiology of ankle impingement is well known because all this anterior ankle pain is known as a soccer player soccer ankle or with a lot of names, and the pathophysiology is injury in hyperdorsal flexion. This is what we thought a few years ago, but we know that it's not the simple pathophysiology, and it is repetitive microtraumatism with the anteromedial injuries by kicking on the ball, or after ankle sprains that can lead to this anterior pain. And it is always mixed impingement with bone and soft tissues impingement in the anterior part of the ankle. You have some osteophytes, of course, and when you see X-rays of ankle with big osteophytes, sometimes you can expect that is the cause of the impingement. Of course, these osteophytes are rising at distance of the capsular insertion. They are not inside the capsule. That histological findings that we know now, with uncontrolled ossification. But on the soft tissues, there are, of course, inflammation and infiltrations of all the capsules and ligament at the beginning, leading to fibrosis and hypertrophy that are creating and increasing the anterior impingement. So the pain basically is mainly due to the inflammatory soft tissues and not only on the osteophyte. That is that if you just remove the osteophyte, you won't treat the impingement. You have to treat soft tissues and bone part in the same time. For the patient, basically, it is always a young athlete with supination trauma histories, and he is complaining of anterior ankle pain. When we compare to the patient with OCD, that like Helder shows you, it's not the same patient. They show you where they have the pain. It's anterior ankle pain, with or without effusion, and with sometimes instability, subjective instability symptoms. So at inspection, most of the time there are nothing to say for the inspection. Sometimes you can have talofibular groove swelling or recurrent edema, but most of the time there is no sign. Palpation is crucial because by plantar flexion to dorsal flexion, you will provoke the pain and the patient will recognize this pain. So at this step, you can say there is an impingement or there is no impingement. You can localize on the anterolateral or anteromedial part of the ankle, and you can palpate osteophyte as well. So this is the most important part, and compared to OCD, when you palpate patient, you cannot find any typical pain. By palpation on anterior ankle impingement, you can know if there is or not impingement. So at the end of your exam, you can say there is anteromedial impingement with most of the time osteophytes on this part and on the anteromedial corner, or anterolateral impingement. Mobilization is important to know if there is stiffness or not in dorsal flexion, and anterior pain in hyperdorsal flexion, but there are a lot of false negatives. What is important, can you put the video, is this test for the anterolateral impingement. You put the patient from plantar flexion to dorsal flexion with your thumb palpation on the anterolateral groove, and it will provoke and increase the pain because you push the synovial and fibrotic tissues inside the joint, and you create the pain. This is very sensitive and specific, and it's very important to do these tests to know if you have or not an impingement, an anterolateral impingement. Of course, you have to rule out the main differential diagnosis, that is a laxity, an anterolateral or lateral laxity of the ankle, because this is not the same problem. And that's most of the time, it's sometimes difficult to know, because if you have this big laxity, of course, you can say the problem is not only an impingement, but it's a problem of chronic instability, but it's not so easy, and you will see that there are new things to say about impingement. There are some criteria for the anterolateral impingement, because for anteromedial, it's quite easy. You palpate on the anteromedial part, you feel osteophyte, there is impingement. But for the anterolateral, you have to be sure it's not a problem of laxity. So you describe the criteria, and you have to have at least 5 of these criteria to say there is an anterolateral impingement or not. And what is difficult is to know about hyperlaxity. This is the main problem, because you have some patient with all these problems, anterolateral problems, and with laxity. So the problem is the problem of laxity. And you have some patient with no objective laxity at physical exam or stress views. And the question is it a laxity or is it an anterolateral impingement? So at the end, you have anteromedial impingement with anteromedial symptoms, osteophyte. You can go. It's quite simple as a diagnosis and as treatment. And you have the anterolateral impingement with anterolateral symptoms, with the Liu criteria, and with the problem of the laxity. At this step, you have to try and to propose for your patient local injection, because it will confirm the diagnosis, and in more or less 30% of the cases, it will treat your patient by decreasing the localized inflammation and without any pain anymore. So it's very important to do this local injection with or without ultrasonography. For the assessment, radiographic is very interesting. Sagittal view can show you this very important osteophyte, but sometimes you cannot see them, and Nick van Dijk described a few years ago the AME view. This is very important, this oblique view, to show the anteromedial osteophyte on the distal tibia and on the neck of the talus that we sometimes miss to diagnose. CT scan can be interesting when you go for surgery to have a more accurate description of the osteophyte and to show you the position of the osteophyte on the distal tibia and on the talar neck. MRI, a lot of patients come with MRI for diagnosis of impingement, but to be honest, it's not very useful, because you can see a lot of things, but it's not the good exam for anterior impingement, especially for soft tissues. Ultrasonography can be very useful, because you can have dynamic and Doppler effect to say there is a localized hypervascularization, and you can see the impingement, the dynamic effect of the impingement with the ultrasonography. At this step, you can propose the treatment, and basically the treatment is arthroscopic treatment, anterior ankle arthroscopy, and if you have to remind only one thing, is to work in hyperdorsal flexion to create your working area and to remove the soft tissues, the inflamed soft tissues, the fibrotic tissues, scary tissues, and the osteophyte in the same time. So you see, this is the best indication for anterior ankle arthroscopy, and you will have 4 working areas with the distal tibia, the talar neck, you have to treat it in the same time, and the malleolar lateral and medial malleolar groove. And by going step by step and systematically in these areas, you will treat all the impingement, anterior impingement in your ankle joint. So this is what we can see. At the beginning, you begin with your synovectomy, anterior synovectomy in hyperdorsal flexion. So you will treat the soft tissue impingement by resection of the inflamed soft tissues. So it's depending on what you see. If there is just localized inflammation, you are treating, you are making a localized debridement. If it's more vast impingement, you will treat all the inflamed soft tissues. And after, you will remove the osteophyte in the same time. So you work in full dorsal flexion, hyperdorsal flexion, to avoid cartilage damages, and you will remove progressively all the osteophyte. Don't forget to treat the talar neck osteophyte, because they are always missed or oftenly missed to treat the osteophyte and the impingement. And when localization is the anteromedial osteophyte on the corner of the distal tibia, and you will treat it by sometimes the accessory portal, and to remove this large osteophyte that is very frequent in soccer player, and it's not so easy to see them on X-ray, and you need the AME view, and by arthroscopy you have to treat them and to remove the entire part of the malleolus, medial malleolus, to treat this patient with this anteromedial impingement. So this is for the treatment. The question is how to treat them with reliable and safe techniques. So if you go from the ankle joint to the osteophyte, the risk is to have remnant bony process here from the capsule and here on the talar neck, and to have remain symptoms. So this is not the good technique. The good technique, and Nick Van Dyke insisted in these courses to say you have to go from the beginning of the osteophyte, from the insertion of the osteophyte by releasing the soft tissues and going progressively up to the joint line, and to avoid to miss some part of the osteophyte. So this is at the end what you have to see. And what I say to my resident is, don't forget to have like a concave part here and concave part here on the talar neck, and that is a good tool to remember. You have a complete removal of the osteophyte. So that is what you have to see at the end, and you have to check different parts. This is on the capsule insertion, on the joint line, and on the talar neck. And at the end of your procedure, if you check these parts and there is a smooth removal of the osteophyte, you can say it's finished, and you can finish your procedure. So the procedure is very easy, with quite a short learning curve, and this is for the post-op, quite classical. So what can we expect for the results? This is the kingdom of arthroscopy, I think, for the ankle impingement, anterior ankle impingement, with better functional outcome and less complication and faster recovery. So you have to, if you have to begin with ankle arthroscopy, begin with ankle impingement. It's a good indication with fast recovery and not a lot of complication. So the technique is very safe now, and you can expect 70 to 100% of good to excellent result with not a lot of complication. With this standardized technique, we made a series 9 years ago, a multi-center series, and we had almost 90% of excellent result, and a lot of rate of satisfaction for the patient. That is very interesting, and 70% of the patient would do the same procedure and could do their sports activities at the same level. That is very important, and that's what we want for our athletes. But what we learn is always more interesting with the bad result, and we learn that for more old patient, that is for 45 versus 34, the results were less good. And the same with the delay from the beginning of the symptoms to the surgery, and with the presence or not with chondropathy, and Nick Van Dyke showed this in the same time. So these are not a good indication, but you have an improvement for your patient, but not with the very good functional results. But this is not so. What can you bring to